A lot of times we print education sheets that we have and we say, just ignore this part that says cancer. You're getting this med, but for a different indication. And then you have to really point out what our goals of care are. You're using the information that as oncology nurses we like and love, but we're having to cross it out and say, just read this portion and just do this here. And that can be challenging for the nurse and probably confusing for the patient.
You're listening to the ONS Podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between.
Hello, and welcome to the ONS Podcast. I'm your host, Tailor, Oncology Clinical Specialist at ONS, and today we're talking with three guests about patient education for cancer treatments and how nurses can tailor that education when these medications are used for non-oncology indications. This episode provides free NCPD contact hours. To receive credit, please review the episode notes for any guest disclosures before listening. Following the episode, complete the evaluation linked in the notes. Today, we're talking with Lizzie McMahon. She's a professional practice coordinator for the Solid Tumor General Oncology Clinics at Fred Hutchinson Cancer Center in Seattle, Washington. We'll be discussing the common education needed for most patients receiving antineoplastic medications. Thanks for joining us today, Lizzie.
My pleasure. Thanks for having me.
When nurses provide education and other cancer treatment education to our most common patient populations, what are the basic elements that are important to include?
So it's important to start by confirming the patient's understanding of what treatment they are receiving and why they are receiving it. This is often called the indication or goals of treatment. The nurse should also reinforce treatment contraindications for starting or continuing on the planned treatment. A common example of a contraindication would be like pregnancy. The next essential elements of treatment education are the medication start date, administration schedule, and duration of therapy, especially for treatment regimens that are given on a cycle, like many IV chemotherapy. The nurse should also discuss common and high-risk side effects for each cancer treatment medication, emphasizing what would be an expected side effect and when the patient needs to call the oncology team or emergency services. This is also a great time to discuss side effect management or what the patient can do at home to both prevent and treat expected side effects. For example, discussing scheduled and as-needed nausea medications or frequent mouth care to prevent mucositis. Another important education element is safe handling of the patient's body fluids at home to prevent unnecessary hazardous drug exposure. And then for any treatment that a patient needs to take at home, like oral chemotherapy, for example, the nurse should also educate on safe handling of that medication, proper storage and disposal, and what to do if the patient misses a scheduled dose.
That's a lot of stuff for them to have to remember, right?
That is a lot of stuff I have to remember.
So how can you best assess a patient's readiness or willingness to learn before starting education?
I usually start by asking the patient if now is a good time to discuss what they can expect with their upcoming treatment or whatever education is scheduled. As you said, it's a lot of information, and you want to make sure that the patient is ready and prepared to actually commit and understand and be prepared to proceed with education. So, like I said, it might be a simple question, but it gives the patient agency. A great follow-up question would be to ask the patient what they already know and what they're most concerned about or what their biggest questions are. So this way, the nurse can tailor their education to make sure to focus on what the patient doesn't know yet and what they're most concerned about, while still touching on all the required education topics. I wanted to note it's also important for nurses to continually be assessing the patient's readiness to learn throughout the education session, looking for nonverbal cues or verbal signs that the patient is overwhelmed or anxious, because this is going to interfere with their ability to take in new information. Using the teach-back method is really important because it's asking patients to repeat back what they've been taught in their own words, and it confirms that the nurse explained a topic correctly and that the patient did understand the essential information presented.
It's a really good point. And I love your message of, what do they already know? Because that gets to not only what do they already know, but what sites have they been looking to and listening to get information, and is the information they have accurate?
Exactly.
What learning aids or tools can nurses use to enhance education?
Teaching something in multiple ways will always enhance patient understanding, especially including elements of hearing or auditory learning, seeing or visual learning, and doing or kinesthetic learning if possible. So some tools would be like patient education handouts in the learner's preferred language. These are often easily accessible for any cancer treatment topic. And if teaching in person, printed handouts can also be used by the patient to take notes or highlight key points, which can help them retain the information better. And they can use them for future reference. A printed calendar of the patient's treatment, especially for complicated regimens, can also enhance the nurse's discussion of the medication administration schedule and cycle timing. Videos are also a great tool to enhance discussion-based education, and a lot of reputable organizations, including where I work at Fred Hutch, creates patient education videos that can be used to teach topics like side effect management or hands-on skills like how to administer a subcutaneous injection or manage a central line at home. Videos can be easily rewatched by caregivers as well, who may be helping with any home care. And then if patients need to do hands-on skills at home related to their treatment, it's ideal to have them practice the skill first with a nurse. I know it's not always possible, but having practice equipment or supplies available allows the nurse to first demonstrate the skill and then have the patient or caregiver practice doing the skill back with real-time coaching. For example, if I was going to teach a patient how to give themselves a growth factor injection at home, I would demonstrate correction injection technique with a syringe and needle into maybe some fake skin or an injection pad, and then have the patient or caregiver show me how to do that same skill. So any type of hands-on learning will definitely help with knowledge acquisition and retention. I always like to note, regardless of the learning tool that a nurse uses, it's essential that the information is simple and clear to avoid opportunities for confusion. Avoid handouts or verbal instructions that have medical jargon, is overly detailed, or has complex sentence structures.
I like that thought a lot. And there's tying that back into the very beginning when you were talking about the patient handouts and how they could take notes on it. I never even thought about it, but it would have been really good to always have like a pen and a clipboard that I took in with me when I was doing education. So you give them permission to write on those papers too.
I agree. A highlighter is great too.
I love me.
Same.
When a patient's family and caregivers are included in education, how can nurses support education to support their learning needs as well?
Family and caregivers are, of course, essential in providing or supporting the patient throughout their treatment, and having them included in education visits is incredibly helpful. So when a nurse is assessing the patient's readiness to learn and current knowledge gaps, it's also important to assess any caregivers who are present. Ask the caregivers how they learn best and try to incorporate their preferred learning styles within the education session. And I always like to remind people that if the family or caregiver speaks a different language from the nurse, make sure to have a certified interpreter present so that they can hear the education in their preferred language. Encourage the caregiver to ask questions throughout the education session, and continue using the teach back method that I had mentioned before to confirm shared understanding.
How do you manage if a patient has got multiple caregivers or rotating caregivers to make sure that they have that information when they come on board?
That is a great question, and often the case. I first ask the patient their preference. Do you have a consistent person that you want to have involved in education, or a primary caregiver? Who does the patient want to have as their primary advocate? If the answer is everybody and anybody, then typically having some sort of trail of either clear documentation of who was present and what you discussed, maybe sending a MyChart message or electronic messaging to the patient after the education visit of here are the topics we discussed and here's who was present, just to refer back to and keep everybody on the same page.
What are some other methods that nurses can use to reinforce chemotherapy and cancer treatment education throughout the entire course of treatment?
I always recommend that it's better to have shorter but more frequent education sessions throughout treatment instead of a single lengthy and very comprehensive one at the beginning. Think of every phone call, electronic message, or scheduled visit with a patient or caregiver as an opportunity to reinforce key education topics, especially for details that keep the patient safe at home, like when and how to contact the care team or emergency services. Never assume that the patient has heard or retained something, even if the nurse can see documentation of a previous education session. Treatment for cancer or for non-oncology indications, it's really complex and it's emotionally difficult. And it might take multiple instances of education for a patient or caregiver to absorb even basic details. And just like at the initial education visit, continue to use multiple ways to teach patients throughout their treatment. I'd mentioned this, but sending a written message after a phone call can be great to summarize key steps or next steps or key action items, or providing the patient with a handout or a video that directly relates to their new side effect or ongoing treatment monitoring, for example. Continue to involve the patient's caregivers in conversation, especially if the patient's treatment plan changes or if they need to start doing specific home care measures to stay healthy.
And you can use that same methodology, like if you're going into a second or third line of treatment, that you can just go, okay, we've already talked about this, so let's talk about here's some differences that you're going to see with this regimen.
Exactly.
How can healthcare professionals evaluate what might be their own hidden or implicit biases related to how they may provide patient education?
Healthcare professionals can start by taking note of how they communicate new information to patients. For example, do they lean towards using medical jargon or complex sentences instead of simple, concise language that might communicate the same concept in a way that is easier to understand? Do they find themselves talking very fast or in a tone of voice that could be considered aloof or condescending? And what about their nonverbal posture and behavior? And what does that communicate to others? If you, the healthcare professional or nurse, find yourself going into an education session feeling very stressed or anxious, try to take a moment to stop and reset before entering that patient's room. Try to appear relaxed, talk slowly, and really focus your attention only on the person in front of you to help them feel comfortable and safe asking clarifying questions and advocating for themselves. And another common bias with patient education is assuming that the learner has a higher level of health literacy than they really do. And as a reminder, health literacy is someone's ability to find, understand, and use information to inform their health-related decisions and actions. As a healthcare professional, do you ever find yourself making assumptions about if the patient understands their diagnosis and treatment based on how they may look, act, or present themselves in a healthcare setting? And remember that someone might appear to understand what is going on, but that doesn't mean that they truly do. Always stop and verify that the patient or caregiver can repeat back essential details about their treatment or anything else that can assure the healthcare professional that they are safe at home. Of course, these considerations are a great start to evaluate bias.
Those are some excellent points. And I think that the people listening to this can take a little bit away from that. Thank you so much for joining us today, Lizzie, and for sharing information about general education for our patients. And I hope you have a good rest of your day.
Thank you, Lenise.
Brandy Thornberry is an outpatient infusion and VAD supervisor at Logan Health in Kalispell, Montana. We'll be discussing education for patients receiving antineoplastic medications for non-oncology indications. Hi, Brandy.
Hello, how are you?
I'm doing well. Thank you for joining us.
You're welcome, yeah.
Oncology nurses may need to provide education to patients receiving chemotherapy, targeted therapy, or other immunotherapy agents for non-oncology indications such as autoimmune or rheumatology diagnoses. For those patients receiving those therapies for non-oncology indications, what type of questions or concerns do they have about the treatments, and how do you address those?
I think a lot of times when they show up for their first infusions in the beginning, in the age of the internet, they've had some education a little bit from providers and looked it up online, but it can be quite confusing. I think as the topic of today's discussion is, a lot of these are oncology meds or immunotherapies, MABs that can be used to treat autoimmune issues, but are also sort of indicated in a lot of cancers. So those can be questions. A lot of the education sheets and the products for them explain it like this is cancer and more of an oncology perspective. So occasionally they can show up and be confused by it. I do feel like they come a little bit less prepared than our oncology patients. You know, our rheumatologists and neurologists, they sure try, but they just don't have the support in that realm either. They're full of every question you can imagine. They've never been to an infusion room. They don't know what to bring. Can they drink water and have their meds beforehand? It's a full gamut of really preparing them to get these for autoimmune or rheumatology type issues.
You mentioned a little bit about how the patient education information is out there for cyclophosphamide or for rituximab is all related to an oncology diagnosis. How do you take that information that you have and give it to them and not have them be scared about them receiving cancer treatment?
Part of it is, I think, a special ability that we have as nurses, but we all find the resources, oncology nurses, right? ONS, you guys print out amazing things and for our patients that's standardized, that's really great education that tells us what to do. It's our rule set. So we're going to use that to help these types of patients. When we get those, a lot of times we print them out or education, sheets that we have, and we say, just ignore this part that says cancer. You're getting this med, but for a different indication. And then you have to really point out what our goals of care are. We're not curing, or maybe we are, or we're here to manage your symptoms. And you're using the information that as oncology nurses we like and love, but we're having to cross it out and say, just read this portion and just do this here. And that can be challenging for the nurse and probably confusing for the patient. And again, this is a digital time in the world. They can find things on their own. They come with all kinds of things that they found on the internet or that kind of stuff. So you're having to kind of tailor it. And then I think here, specifically for us in our location, when we're doing that repetitively, we end up making our own education sheet. We're lucky at marketing and we use that. And that takes a lot of time and bandwidth, I think, from our nurses and our unit-based councils that do that. But when you're repetitively having to explain it, eventually we'll do that. So I think that's a frustrating piece because there isn't necessarily a beautiful education sheet for someone with vasculitis getting cyclophosphamide or someone with Crohn's or something getting another med. So
it's a really good point. And it is time intensive to make up your own patient education sheets and keep them current. But if it keeps the patient more comfortable, it sometimes makes sense to go down that route.
Right. And in a time frame of, these are lower acuity patients. I beg to differ. They come in less prepared. They don't get a chemo teach. They don't get prepared. Like I said, I think, our providers are out there and they're being forced to see more patients and they're doing their best to explain, you're going to get this for your GI issue. And they're doing it, but there isn't a beautiful setup. I think oncology has just really nailed how to do it and has the support services. And we're just missing this window over here, this set of people. And we're, as infusion nurses, right? Not just oncology infusion nurses, we're hybriding it all together. It's sort of a little MacGyver if you're old like me and have watched that show. I just aged myself.
I'm with you.
Yeah.
How do you find yourself reinforcing education throughout treatment in these non-oncology situations?
Reinforcement, I think, is always really important in any patient, but micro-learning, I've learned a lot about and done some evidence-based practice, little bits of it. People can handle what they can handle at the moment. So little doses, and you want to do it, as we talk about, being able to reinforce it constantly over time. You want to explain it to them. You also want to be able to have something for them to take home so that they can also look back at it when they're like, oh, realistically, they're probably getting maybe 10 to 15% of every time of something that you're saying. And so if we catch them every time over and over again, pretty much I always tease them and I say, before too long, you're going to be on the payroll. We'll get you there. That's a big portion of it, but it takes time to get there. And if they're overwhelmed because they've never been to an infusion room, they don't know what it looks like. They Googled that this is a cancer med, but they don't have cancer. Where is their head at? They're not catching everything that we're saying. So you kind of try to do that. So I think micro-learning, reinforcing it, always teach back, right? Old school nursing doesn't change, I think, in this situation. And maybe I think another part that I've learned, and other nurses, I'd love to hear their opinion or yours, is normalizing being in an infusion room and that this is normal for them. It's a normal part of it every time because they're going to see a lot of different things. So I think that's always important.
100%. I agree with you very much on that. What are some common misconceptions about providing education for non-oncology diagnoses?
I think that I've mentioned it a little bit or touched on it, but I think these patients, it's assumed that somehow they need less education than an oncology patient or less put into them. It's not less, it's just different. They're going through things that are going to last them their lives, possibly, likely. And then I think when, as a supervisor, and just full disclosure, I'm a new supervisor, still under a year. So I'm like shocked into learning all these things every day. But part of it is they're not a lower acuity. Lowering your chair time, if you're talking business now, they need more. To saying this is a 1 hour time for a first time person, maybe in a few months, depending on what they're getting. But day one, no, it's not lower acuity. Again, they need different education. They might need more time with you because they don't have all those wonderful support systems, nurse navigators, and that oncology, chemo teaches, all that's been out there and created in the oncology world, they're not getting.
That's true. And I think the doctor's offices, the rheumatologists and those groups of docs that are sending those patients over, they don't have the resources. They may have a nurse in their clinic, but they may mostly have MAs and they're not set up to do the chemo teaches like the oncology offices are. And they can't bill for those teaches. So unlike the oncology world.
And that's a big part of it. Their world and their specialized is in that area. And then throw in an area like mine where we're so rural, we have only one rheumatologist office. We have only one neurologist office. And we have a massive growing population from COVID and people moving here and just so it is. But our medical services haven't grown with it. And so they care so much about their patients and they want to get them these amazing meds because immunotherapies are the future. Obviously, I think we all, as oncology nurses and ONS, everyone can tell that. But they don't have the time, like you said, to walk them through A to Z. Okay, now you're going to go in and you need to drink water so we can get an IV and all the little steps that we do to care for our patients. So
you've talked a lot about things that we may not think about, chair time for first time teaches, that sort of thing. Is there anything else about this topic that may not be discussed, but you think is important for people to know?
I think there's a couple. I think health literacy, especially in areas like mine, we're not the only rural nurse, hopefully listening to any of this or experiencing any of this. When you have, and this is just data, I think we all know, when you have an increased poverty level and kind of in our area, your health literacy rates, even just your literacy rates go down. So here where I live in Montana, a lot of Montanans can read. We're very lucky. We have a great 90% of Montanans can read, but 70% of those read at a third grade reading level. So when we're providing this information to our patients, we're having to think about how it's written specifically in terms of health literacy, and can they understand it?
Can you think of any other additional resources for patients or nurses who would want to learn more about this topic?
I am a big fan of the ONS podcast, so I listen. So this is a big resource that has taught me a lot about being an oncology nurse and meds and keeping up with current things. Also, the website, ONS, that's symptom management. But I think the biggest piece too is just knowing that we're always going to be continuously having to keep up with these new therapies especially for this population, because we know they're just not as supported right now. Maybe one day it won't be, and there's just so many new meds coming out. So using your resources, I think in certain ways, mouth sores are mouth sores or diarrhea is maybe diarrhea, kind of, you can, again, keep MacGyvering things.
Brandy, it's been great talking with you. Thank you so much for sharing your experiences.
Yeah, anytime. I appreciate it.
Jennifer Lynch is a professional practice coordinator for BMT nursing at Fred Hutchinson Cancer Center in Seattle, Washington. We'll be discussing patient education for stem cell transplantation and considerations for non-oncology indications. What are the basic topics nurses should cover about stem cell transplantation and chemotherapy for patients receiving chemotherapy for transplant?
One of the first things that patients often ask are, how are they going to feel and when? So we created a visual timeline based on kind of average anticipated side effects, recovery for patients to kind of help better prepare. So the feedback from patients has been really positive with the visual aid. So we talked to them about how they're going to feel initially after their chemotherapies, especially those first couple of days. And then as their counts drop, we'll talk about what to focus on the fatigue, nausea, vomiting, their appetite, taste changes, elimination patterns are going to change. Whether they're inpatient or outpatient, what does that look like? We want to talk to them about infection prevention. That's very important. That really doesn't change throughout the entire course. We really want them to practice good preventative measures for quite some time. So what does that look like for them? How do they have to alter maybe their shopping practices or eating practices? And we have classes to help with these as well, written literature, like I said, the visual timeline, so that we are making sure that we're capturing all types of learners to give them this information. We also talk to them about when they are going to feel better, when we expect these symptoms to go away, so that they can see, all right, I just have to get through this low part where they drew, and then I can see myself recovering. Now, sometimes it's a little unpredictable, so we have to kind of have them keep in mind, like, just still be on the lookout for these things and report them to the team as soon as possible. They're with us for a couple of months. And so we talk about what going home looks like and what survivorship looks like as we progress, giving patients the whole comprehensive look at what are they going to feel acutely and what can they expect down the road and what is unpredictable, and to kind of be ready for.
So it sounds kind of like you're giving them the whole gamut of stuff, but then you're chunking it up as it's more applicable so that they're going to be able to pay attention to that piece and not get buried by something that I need to worry about going home, but I'm just going through transplant right now.
So we try to not overwhelm them with information, which can be hard. That's very challenging. And at the same time, we don't want them blindsided. Oh, I didn't realize this when I went home or months after. So definitely wanting them to be prepared in some way and not feeling unpleasantly surprised by things.
You talked about a lot of the main topics you talked about with nausea and vomiting and fatigue and elimination and infection prevention. Are there other basic topics that you want to make sure and cover with these patients?
Absolutely. Graft versus host disease. If they are an allogeneic transplant patient, so they're getting stem cells from somebody else, we want to make sure that we talk about that, what to look for, how it manifests, but there's different degrees, and that can be a little bit harder to predict who will experience what. We're getting a little better at it, but right now it's still kind of a watch and wait. So it often will show up as a rash. We want them to stay out of the sun because that will definitely trigger that. Nausea, vomiting, loss of appetite, they should be feeling better and have a good appetite by a certain point. And if we start to see that kind of regress or these symptoms reemerge, then we are suspicious of graft versus host disease. And then we talk about how we manage that, which is currently a couple of different ways, but often it's high dose steroids. It's high dose prednisone. And then that has its own teaching that goes along with it, opens up a whole load of prednisone can of worms. And then what do their other medications look like? How long are they going to be on their immunosuppressives? How can family members help protect them? Transfusion independence, when we anticipate that. If they had a blood type from a different type of donor, they will convert to that donor's blood type eventually. So what does that look like for them? That looks like a lot of O positive blood, possibly for quite some time, and then they'll eventually become their donor's type, whatever that might be. How much time do they have to spend in clinic? Fluid and electrolytes. How can they do that? How can they manage that? When would we expect them to not have to come into the infusion center daily to get IV magnesium or home infusion? Memory and concentration is another one that I don't think gets talked about enough, as well as sexuality. That has a lot of downstream effects down the post-transplant that can really impact quality of life. So I think we can get a little bit better at addressing those, but those are some of the other topics we'd want them to feel free to discuss with us, with their team.
Definitely some of those are ones that you wouldn't see with a regular oncology patient who's undergoing some standard therapy. Speaking of that, patients undergoing stem cell transplantation likely will have been through multiple lines of treatment before they walk in your doors. They've had chemotherapy, they've had immunotherapy, they've had biotherapies, they've had all of these. How can nurses, transplant nurses, tailor their education about chemotherapy and those drugs and transplant to reflect and acknowledge the experience that they've had in the past and discuss how it might be different going forward in this realm?
We do see a whole range of knowledge base for these patients. So what I like to ask going in, well, first of all, we'll know their history beforehand. We'll know if they're chemotherapy naive or not. But I always like to start off with, tell me what you know. Tell me how your last experience went with these treatment regimens that you received. And then kind of build off of there. Transplant therapy is usually a lot stronger and a little bit more toxic. So those effects are felt sometimes they're a little more prominent. They can feel fatigued for a lot longer than their previous chemo. Their counts might be lower. They might have more appetite issues and GI issues for a little bit longer. So making sure that not to scare them that this is, oh, it's similar to what you had, but you might feel worse, but preparing them that this is different from your previous treatments, especially if it's myeloablative. If we're not giving myeloablative therapy, then it might look very similar to what they've had in the past. But that recovery is different, especially if you're talking about a donor's immune system coming in and setting up the work and shot and regenerating their cells. So basically starting with what their baseline knowledge is and having that feed on topics that we talk about. And yes, what will be similar, how they managed it before. Well, tell me what you took beforehand. Did Zofran work well for you? Did Composite? Sometimes by then they know what drugs don't sit well with them and what does work. So that can be helpful. But having them know that this is slightly different from what they might have experienced in the past.
You also mentioned chemo-naive patients, and that was actually going to be one of my other questions. It's in non-oncology diagnoses that may undergo stem cell transplant. How does the education look different for those patients who might have sickle cell disease or other autoimmune disorders, and they have never received this type of treatment before?
I really want to spend time with those patients to make sure that we are not assuming that they are coming to us with any knowledge or experience. I want them to be able to come to us with questions and trust their healthcare team and really sit down with them and say, okay, you don't have cancer, but we're using the word chemotherapy where we're talking about cancer drugs. Again, tell me what you know. And we're going to probably spend more time going over some of the basics about blood stem cells, types of cells that they grow into, how your body fights infection, what they're going to be at risk for. The side effects can be pretty scary when you're talking about them, especially back to back. So making sure that we are delivering the information that doesn't put them in a panic mode, that they're able to say, okay, not looking forward to this, but it sounds like this can happen, but we know what to do. So making sure that this is an expected side effect, it's temporary, but we have a clear action plan on how to help you through it. So a lot of reassurance as well. And just taking into consideration that, yes, this might have this whole other layer of anxiety to it because of the unknown.
And all the stuff they've heard from other people who have undergone cancer treatment for cancer.
And everybody's treatment looks different. And a lot of transplant patients will look to their friends and family's experiences or online experiences. And really, that can be very scary if somebody has a hard time. But kind of, again, bringing them back to that was that person. You're a totally different body. You have a totally different disease, possibly. You have a totally different regimen, history. This might look a lot different for you and hopefully better than what you expected. I would love for a patient to be able to say, that wasn't as bad as I thought it was going to be. Then I know we've done our job.
I always loved it when I got one of those.
That's a win.
Exactly. How can healthcare professionals evaluate their own hidden or implicit biases that they might have related to patient education and transplantation, either how you provide that patient education or for the patients who are coming to you for transplant?
I think this requires a lot of self check-ins and acknowledging that these biases exist, whether we think they do or not, and they might come out in different ways. I like to check in with myself and just say, what assumptions am I making about this patient and their caregiver? Even if I've met them before and have some kind of knowledge about how they like to learn or what they know, really just not making assumptions. Because what you do when you make assumptions is you're dialed in to that thing, and that's going to alter how you teach, how you approach, how you look to that patient. So just being mindful of assumptions and then being mindful on communication and verbally and our body language as well. I make sure that I want to be as approachable as possible and just be dialed in, because if I start to see that patient or caregiver, maybe you can tell when you've lost somebody, or they've had too much information, the glazed look, really making sure you're reading the room. I want to be dialed in to how that patient is feeling and taking in that information when I'm talking to them. I don't want to talk to them about what to expect or how to navigate transplant just to check a box or just so I can chart that I did. This is a moment of empowering the patient through this, on telling them what to expect and how that's okay. We've seen this before. We know how to deal with it. And here's what we're going to do. And here's what you need to focus on. What are your responsibilities? I think checking in with your assumptions, making sure that comfort and trust are really the environment that you need to be bringing to the patient and the caregivers.
What are some common misconceptions about stem cell transplantation?
I laugh because I always think of a friend who I've known for years, and I didn't realize until very recently that she thought stem cells deal with unborn children, and that's where our stem cells come from, and that's what we do. And I had no idea that there was. So I really wanted to, I think, just making sure that people know there's all different types of stem cells. There's all different types of therapies and requirements and things like that and how they're used. I want to make sure that we're talking about blood stem cells, baby stem cells that grow up to be anything they want as long as it's a type of blood cell. That umbilical cord blood is, if we do get a stem cell from an umbilical cord, it's no harm to mom and baby. The baby has been born. This is something that is voluntarily done and is, like I said, no harm caused. But also the science behind it is very well established and tested. And this type of science is just a fantastic discipline for checks and balances and making sure that we're doing evidence-based practice with no harm done. And so just making sure they know the type of stem cells that we're talking about, and the practice in which it's conducted in is highly regulated, and this is beneficial and not causing intentional harm.
Thanks for sharing this with us today, Jen. I enjoyed talking with you, and I hope that our listeners learned something more about patient education and transplantation.
Thank you so much for this opportunity. I really appreciate it, and the knowledge you guys share.
Thank you for listening to the ONS Podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org and ons.org/voice. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.